Okay. The big red thing came on. We are now live. Okay. As y'all have already figured out, I'm not a professional podcast host. So we're just going to do this. Welcome to the Commercial Real Estate Morning News Show. And I have my guest today. This is the Healthcare Real Estate Edition. Yay. And we've got some people in the house who know what they're talking about because I don't. So, which is awesome. And I'll let them introduce themselves. My longtime guest, Deanie, go first. Introduce yourself, buddy.
Yeah, Deanie Taylor. I'm CEO at Landmark Healthcare, privately owned development company nationwide. Only do outpatient medical buildings, and this is my third stop in medical real estate in about 30 plus years. So, looking forward to it, Amy.
All right, awesome. And John?
Hey, John Klopsch. I lead the project management group at Tenet Healthcare. We're headquartered in Dallas, but we have facilities, hospital campuses in various parts of the country, and then a lot of outpatient surgery centers all across the country, which are run by USPI, part of Tenet Healthcare.
Awesome. Very cool. And Chuck.
Yeah, I'm Chuck Denk. I bring about 40 plus years of healthcare experience in planning, design, and construction. Currently partner with Colorado Healthcare Partners out of Denver. We are kind of a boutique group that develops medical facilities for outpatient outreach for the systems here in the Denver market.
All right. Very, very cool. So the top story we want to talk about is 2024 was the year of the medical office building, apparently, someone said, Globe Street says. And so I wanted to see if we thought in 2025 that would be the same phenomena, or is there anything else trending in the world of healthcare real estate? So anybody want to jump in on that one? By the way, my two new guests, I just throw stories out. And you just have to jump in. It's a free for all. So FYI. Deanie, you want to jump in on that one?
I think it's funny that they said 2024 was the year of the medical building. I don't know. I don't know how you measure that, but I think clearly 25 and 26 hospitals and health systems are poised to expand their markets with outpatient medical buildings. So I think there's a real opportunity there, whether they are owned by the hospital or health system or whether they are owned by developers or other real estate owners. It's definitely going to grow. We can already see what's building in 25 now that needs to get started this year or next.
Yeah. Is it in just major markets? Are you talking like rural, suburban? What is the drivers in the?
Amy, I know I say there's nobody in Idaho and Montana, so I'm not really worried about them. But in the major markets, I don't. It's primary, secondary markets, and clearly the Southeast, the Southwest, but to a great extent in the Midwest. It just depends. What that health system has been going through as far as it relates to increasing market share.
Yeah. Okay. Interesting. Anybody else want to jump in?
I just add, as an occupier, we certainly see some activity, a lot in the secondary markets, and then in the areas that Deanie was mentioning, not just new facilities that are being developed or have been developed, but reuse of existing facilities. There's some vacant space out there as well. So we're definitely seeing a lot of activity because, there's a lot of movement to the outpatient setting in healthcare, which we've been hearing about as if it's a new thing, but we've been hearing about that for decades, and it remains the case. So that, the demand is there.
Yeah.
We're seeing the same thing. We've just had a number of hospitals announced here in the Denver market. And of course, the outpatient facilities to feed them, the satellite facilities to feed them, will be the up and coming thing here in 25, 26. It's still a tough market because of the finances that go along with real estate development today.
Yeah.
So I think we'll see a number of system and facility generated work for medical office buildings, of course, on campus.
Yeah.
And hopefully the rents will get up to a point that the outpatient facilities off campus can start to come along to join them.
Interesting. Is it to the point where so when I was in college, I was playing volleyball, and when you play a lot of sports, especially start growing, I started playing sports when I was 10. When I got to college, I wanted a body parts store because my shoulder was hurt, my knees were bad, like everything was like falling apart, even in college. Can we do that yet? Can I go? Can I get a new knee in a day? Can I just like walk up body parts store? Is anything there yet? I'm just curious.
Maybe not quite that easy, but there are definitely specialty centers.
Yeah, for sure, right? And just so walk-up surgeries, are we at walk-up surgeries yet? No. All right.
There's some procedures that sound like that used to be surgeries that are now outpatient visits. So it's not quite a walk-up, but it's a walk-in and after your procedure walk out. I know somebody getting a rotator cuff repaired like that coming up.
Really?
Yep.
Wow. That's pretty cool. That's awesome.
Hip replacements out in a day.
Yeah. That used to be major in the hospital for a long time.
Yeah. So no, that's, well, good. We're getting there. I won't have my body part story yet. We'll get there. All right. We got to talk about, y'all have to educate me on that. The next article talks about the Stark Law and how it's affecting real estate transactions. And someone has to do a Stark Law 101 because I don't know what that means. Does anybody want to take that one? There was an article out in Globe Street about it.
Amy, you just got to have a lease that's real clear. And if you don't do what the lease says, you're violating the law because you're a referral source. It's very different than a retail lease. Or if you have a Starbucks, you're not referring anything to the Target or wherever you're located. So It really doesn't matter. But a doctor with a lease that refers patients to the hospital, if he's using space for storage or something like that and doesn't have a lease, he's getting an advantage, and that's against the law.
Oh, wow.
It's real basic. It's, it's not rocket science.
So, but isn't that how everything works in the world, Deanie?
It has for years until you got caught, and now there are lots of penalties and fines being paid over the past years, and the law is becoming very specific. So, but no, I think it just comes down to everything has to be documented much more thoroughly than the type of commercial leases you have seen in the past that might lead to a lawsuit or something, but it's not a fine that the government will issue that is in the million. Because here's how the fine is calculated. If you refer patients, they go back and look at all the revenue you've generated from Medicare and Medicaid, and you have to give all that back plus a fine.
Oh my God.
So that lease was for 3 years, 4 years. That's a lot of money.
Yep.
That is crazy. And so can someone explain to me what's the beef? Like why do they care? Like what's the big deal?
It's because they are a referral source. That means you are incentivizing them, if you're the hospital or with the lease, to bring the patients to your hospital because you have free rent, free whatever, free space.
Okay.
And if you're the patient and you don't want to go to that hospital, you want to go somewhere else, but the doctor would like you to go to the hospital that's giving him free space. That's the basis why people are complaining, and that led to the laws. But it's been around for years. We all have seen it. We all catch little problems, but very seldom is it egregious, and it's usually a mistake that gets caught.
Yeah.
Interesting.
Fair market value is very important.
The Stark laws are out of date. We're in a time when physician practices being owned by the hospital or by the health system is the norm. The number of independent physicians out practicing today is getting smaller and smaller.
Hmm.
So, it's every one of those doctors that's owned by the system is going to refer their patients to that hospital. They're going to refer their patients to other physician practices for specialties within the system.
Mm-hmm.
So the idea that the hospital is going to bring in outside physicians, put them in their medical office buildings, predominantly on campus, and give them free rent just to get
Customers.
the customers.
Yeah.
That was something we saw 40 years ago.
Yeah.
We don't see it so much anymore. We see more instances of hospitals helping in rural markets, and there have been instances where hospitals have had their fingers slapped for helping some of those rural communities and doctors in rural communities, but you don't see too much of it anymore in the major markets.
Yeah. Interesting. For sure.
We could debate that. I agree with Chuck. It's a market dynamic of whether the physicians in a market are primarily employed by the hospital or not. I would tell you, we own a 200,000 square foot building in Miami, and they're all independent physicians, 3, 4, 5,000 square foot tenants, and you could have this problem with any one of them on any given day. And so we all watch it and make sure we do the right things. I mean, there are still independent physicians out there that this could be a problem with. And when we all buy buildings, the first thing we look for is, do we have a lease problem when we're trying to figure out what to do with the tenants?
Interesting. So is it the landlord's deal, or is it the physician that gets slapped? Who gets slapped, or is it both? Or
Hospital or depending on the extent, the physician. The nice thing is, you really don't see any of the private owners having a problem.
Oh.
We're not a referral source.
Yeah, well, that's true, right? It's just your tenant, and if your tenant,
I have this belief we could get, instead of paying broker fees, we could just give everybody BMWs and get the lease done. It's legal. It's legal for us to do that, not for the hospital.
I think where it happened, where it was a bad case, was when the hospital was the owner.
Exactly.
Oh, I see.
Right.
Okay, so that makes sense. There's a clear line, and that's an easy one. I can even find that one. That I
The
can
other
find
thing
that
is, it's not always just the hospital.
one.
There have been hospital administrators that have been taken out of business,
Right.
outlawed from administering at another hospital facility.
Wow. Okay. Crazy town. All right. So did y'all not know that medical is supposed to save the office market? Did y'all not know that?
I did not.
Where the office market is, they're looking for anything to
You
say.
need to go put your capes on, because you're going to save the day. The office market's going to collapse unless the medical office buildings or anybody comes in to save it, because otherwise it's just. But there's a lot of articles out now how medical is going to save the office market and all these other things. And Jeannie, you and I have talked about this before. As long as it's not like where you got to get a gurney in an elevator, it might be a possibility. I don't know, but have you seen
all the systems? It's all the systems in that building. Chuck's got good experience at what it takes to have a medical building that's functional and what has to change in an office building. I can tell you, it's a lot, and it's not inexpensive.
Yeah. It's interesting. Is it to the point now? Because people are even looking at office buildings are getting so cheap that even the glass and the steel are worth more. Like, I mean, you could sell it off of parts and make money, but is it pencil now to where it could turn into a medical office building? Because some of them are doing them into residential, and that sounds like brain damage to me too, but I'm not sure.
Residential's easier. And
Really? Because that sounds like complete brain damage with the mechanical and the plumbing that you have to turn that into residences. That would
Well,
just,
you got exactly the same problem with medical facilities.
yeah.
Very seldom do the systems that are put into an office building work for medical. They
Mm,
don't have the plumbing. They don't have the HVAC controls that are necessary.
mm,
Many times the units aren't sufficient to provide the CFMs that are needed. So we have looked here, and even when I can, even when I can buy a building for a quarter of what it would cost to develop a new facility,
mm-hmm.
I can't make them pencil.
Interesting.
By the time you go in, do the demolition work, upgrade the systems, you're paying the same price, if not a little bit more, as you're paying for coming ground up.
Wow. Okay. So that doesn't work. So the poor office market's just going to have to figure something else out. Crazy town. So, Deanie, you wouldn't look at it. You wouldn't touch it with a 10-foot pole, or would you? If you were going to look at it.
Chuck's exactly right. And then you add what is really a construction problem. The floor to ceiling heights typically in an office building are not what's needed in a medical building, and that you can't fix.
Yeah.
I mean, that is just that. Then you're really in trouble because of all that is above the ceiling in a medical building that's not in an office building, and it just ruins it. It is very rare that you find a office building you can convert. You might get clinic space in there, but you're not going to get surgery centers and some of the high uses in a building like that. Just not going to make it work.
Yeah. Interesting.
Yeah. There's some real specific cases that have worked in a limited fashion. One example is, everybody remembers Blockbuster Video, and the real estate for those facilities and the searches for the properties and where they wanted to be as far as the demographics go was not too different from where a company, I think it was Emirates, where they wanted freestanding emergency departments to be. And they're small freestanding buildings about the same size. And so they were able to, I saw several of those get put up in Colorado Springs, where it was abandoned building. It had been a Blockbuster Video and it became a freestanding ED. And I've heard of something like that with, I don't think it's happened as often, but I have seen it at least a couple of times, a bank where they had a vault, and for, again, the building similar size, you put a freestanding emergency department in there, and the part of the building where the vault was already has the significantly increased amount of concrete. And so it's a little easier to get it shielded for your CAT scan machine.
Okay. That makes
sense. That's so specific, and that's pretty limited.
Yeah.
Pure
You know,
another example.
Yeah. I was just going to say, by your Blockbuster Video reference, you just called us all old, John. I'm just
Yeah.
It's like if we know who Blockbuster Video is,
Yeah.
you're basically 50-year-old older.
Well, the ones I'm thinking of, I actually rented videos at those locations.
I know, I did too.
And then later saw them, hey, that's an emergency department now. So
Yeah, no, that's funny. What were you going to say, Chuck? Sorry.
Oh, I was going to say, Pier 1 Imports, when they went out, they were perfect facilities, about 10,000 square feet, high ceilings. You could do anything you wanted to inside of them.
Yeah, it's interesting. So if we build buildings today and we wanted to plan knowing that in 20 years, it's going to be reused into something else. Like if somebody was going to be smart about, I don't know, constructing something that could be reused into medical, it's high ceilings, it's being able to adapt to ventilation systems and mechanical and plumbing, right? Like we would have to really think, is that it? Or is there, and maybe elevator shafts that are wide and tall, but what else?
Well, those are pretty big for your first cost. So
yeah, I know, right?
That's the trick. If you're putting the first cost in to make it adaptable in the future, are you going to be around to get the benefit of that?
Yeah, maybe probably not.
parking's another big issue. Most codes allow office buildings and retail areas to be 2-3 parking spaces per 1,000. Doesn't work for healthcare.
Oh, interesting. So how many do you need? 5, 6? What do you need? What's
5 to
average?
7.
5 to 7, really? Wow. Okay. I don't know. Every time I go to a hospital, there's never that much parking, and it's always full. I don't know. I don't think the 5 to 7 is working.
Well, in a hospital, little different scenario, but when you look at a medical office building, if you're not at least 5,
Yeah.
it just doesn't work. You figure a single physician tenant practice, you've got probably 3 to 4 people on the payroll.
Mm.
A one physician practice is 1,200 to 1,500 square feet. Then the doctor's got 3 exam rooms. That means 3 patients plus at least 3 patients waiting in the waiting room.
Right.
It's a lot of patients to have for a small practice. Taking up your parking spaces.
No, that's true. That's 6 people, right, at any given time. Oh, that makes sense.
Mm-hmm.
Yeah, the outpatient space needs more parking than a hospital space,
Wow.
which is kind of strange.
That is kind of strange.
You've got the appointments like Chuck was describing, appointment after appointment. A lot of them overlap. That adds up to a lot of people parking.
You put on top of it the problems that practices are having these days with trying to get their patients through every 15 minutes. It doesn't happen. If you start looking at many of the hospital practices, even on campus these days, it's not unusual to have a 45-minute wait to get into an exam room.
Yeah.
That just backs up the amount of parking that's required.
Yeah, I didn't even think about that. That's interesting. That's and you don't want it to feel like a cattle call either, right? You don't want it to feel like, okay, next, take a number. Like, we actually want to talk to a doctor when you're sick.
But that is what's going on in the healthcare industry today.
Yeah.
Particularly in the case where you do have hospital-owned physician practices. They have requirements to meet based on the performance that the hospital's looking at for the practice. They're trying to push them through. You don't get that time to talk to your doctor for 30 minutes anymore. They're trying to push you through in 15.
Did we lose Amy?
I think so.
It looks that way.
Her picture we lost, but I didn't know if we lost her audio.
Yeah. Speaking, so.
Operator error.
Yeah. We're live, so I guess it's still on.
Yeah. Oh, you guys have probably seen it as well. A little more of a mix of use on some locations where you get the mixed use campuses, medical office space, other types of commercial real estate all mixing together. That's got to be with a parking calculations for all that have got to be rocket science. But those developments get pretty interesting.
You got to get the right use at the right time in those parking spaces.
Yeah, that's true. Time of day is a big deal. Yeah. Good point.
Any kind of residential to it.
As we look at the retail environments, we go in to negotiate and mark off territory. You kind of have to do that when you're into those type of environments. Otherwise, you do have that problem of who's going to park where. We were fortunate in one project where we're virtually sharing parking and with a hotel. Works out fine. They're busy at night. We're busy during the day.
Yeah.
So it allows you to move a little bit on the other side of the road to pick up what you need for parking.
Yeah, that would be a good mix.
Or a text.
John, you being with the system, what do you see as far as the outpatient satellite facilities?
Well, it's mostly surgery centers that we are developing and building and expanding. We're in a mix right now, some acquisitions, developing existing places. They're all joint ventures with physician groups, sometimes also health systems besides ourselves. But we have seen recently the new fully developed ground up type of facility. They're harder to get those to pencil out, and it's because of the higher construction costs, like you all have seen as well. Excuse me. So tenant improvement projects in existing buildings are often an alternative. That's not always the case, but it's just a little. We're doing more of the tenant improvements and fewer of the ground ups. I'm sure that's not going to stay the same forever. But healthcare is real challenging right now with the cost of doing the work on projects, and lease expenses are not going down. But the healthcare reimbursements are just now starting to catch up. It's been a lag with inflation. In any other business, if your costs of doing business go up, you can raise your prices. In healthcare, for healthcare services, you're on long-term contracts and government reimbursements. So you don't have full control over what you get to charge. So that's a challenge across the board for everybody. So that's been that we're hoping to come out of that soon. I think that's why there's a little more optimism for 2025. Some of those reimbursement rates are going up a little bit.
For the independent developers that are out there, it's a tough market. Like you said, land costs haven't come down. Construction costs have increased. Here in the Denver market, we've seen a 30% increase since 2021. Interest rates are double what they were back then. Cap rates. The only thing that hasn't gone up appreciably is rents.
So when I was stuck, was my face bad? Was I like this, or
there was no visual. Your picture went away first.
Okay, well that's good. At least I wasn't stuck in a bad position.
Kept talking about you. We just kept talking about you.
That's okay. That's awesome, because I love that. It's so great. Thanks, Deanie. I appreciate it. At least it wasn't because what I saw on my screen was like awful. I was like
oh.
Too funny. So what were y'all talking about? 2025? I'm back. I'm here. I'm back.
A little mixed use campuses, and then
yes.
We started talking about just general development from health systems and outpatient facilities, what that environment looks like right now in 2025.
So what is the financing like right now? Because it's a mixed bag depending on the industry you're in. So what is it? Did y'all feel the hit like everybody else did? Did people pull back? Like you have different kind of financing arrangements. What's happening in financing now?
Yeah. Well, for our company, for hospital projects, we don't finance things. We pay for our projects, but for our joint ventures, we do finance those. Some of that's regulatory, a little bit related to what we talked about before, but we're in a joint venture, so we go get financing, and those costs did go up, and it has affected many of our deals. So it is a significant factor.
Are you still in the single digit? You're not doing double digit stuff, right? Are you still like 7%, 8%? Is it normal?
I don't know the exact numbers, but I don't think they're out of single digits. They're still down in that range.
Okay. All right. That's cool. What about you, Deanie? You're seeing anything crazy town?
Number wise, construction financing is in the 7s at this point. And cap rates, yield on cost right now to determine rents, high sixes, probably something like that.
Yeah.
And then to get to permanent rates on loans, we're in that low six, maybe,
Okay.
somewhere in there. You got what hadn't happened is you haven't had the SOFR hadn't gone down, so the spreads are
Right.
still in place. Um, for us, and this is a leftover from my REIT days, it's important to look for other sources of capital that's not banks,
Mhm.
and others, because you can develop relationships where you've got a capital source that's interested in your building long term, and you work that out, especially if it's a REIT that's not doing development on their own, because ultimately they want to own a building. And so it's a challenge. You have to really dig at it. Construction costs, as you already heard, are up, and for a market that we've seen rents in the 20s for a long time, it's hard to talk to somebody about a rent that's in the high 30s or low 40s. It's hard, and
Yeah.
that's where a lot of places are going.
Interesting.
Talking triple net rents.
So when you're doing a new development, how quickly what's the lease up period like? Is it leased up before you finish? Or or is it after, or what's it like now?
We hope. We hope it's leased up.
Yeah.
Um,
I wouldn't I would not do a building unless it's with an existing client for less than 75 to 80% pre-leased. I wouldn't even start construction.
Oh, okay. All right. So you have to
I mean, the
lease them.
day of a spec medical building's over. I
Mhm.
mean, that was 15 years ago. And the 50 percenters are you can look at them, and those many times you're not successful, and the longer it takes to lease it up, you're losing money.
Right. So if you get it, so if you're leasing it so you'll wait to move dirt until you've got it leased up, at least to there.
You got
But
leases signed, yeah. You got to
yeah.
have leases signed, because otherwise, when you go to get financing, they look at you like you got three
Yeah.
heads if you don't have 80%.
Oh, okay. All right. I was just going to say, if that's a requirement for lending, then that's okay. That's what I was wondering. So
they're looking for projects that are cash flow neutral as a
Yeah.
minimum.
true. Right.
Well,
Yeah.
if you aren't leased up enough to pay the mortgage, they have no interest in you unless you have very, very deep pockets to make up the difference.
Yep.
Yeah.
So what's are there any sort of changes in the lease terms like lately? Is there any sort of trends changing in the lease? I mean, I'm typically they're probably 10-year leases that you're hosting with normal escalations. Is any other changes there? Or is that, I mean, I'm just curious. Is there like a big, huge demand for the medical office leases? And so therefore you can ask for, is it the year of the landlord, I guess, or the year of the tenant, or is it the same?
The market out there is a two-way street. As building developers and owners, we're looking for the 10-year, with some extensions if possible. The doctors nowadays, particularly in the independent practices, they're looking for 3 to 5 years.
Okay.
So it's a negotiation, and they don't understand the implication and the impact of their tenant build outs, those types of things. So it's become more difficult.
Interesting.
Yeah, we're usually trying to balance how long we want to be in the space if we're going to lease up a space, and depending on the length of the lease, what kind of TI allowance we're going to get, and what that's worth to us. So, but it's not a big shift from the numbers may be different, but the dynamic I don't think is really different.
It's pretty much the same. Yeah.
We haven't changed lease terms on anything major. The numbers, the TI allowance, those are the things,
safe.
as well as the length of the lease.
Interesting. Pretty safe. Okay. It's just curious. I think that's That's when you know the market shifts between landlord and tenant, was when the lease terms start changing and people are having forced to do things out of the norm. So I was just curious to see what was happening.
And John brought this up as you look at further renewing and renovating existing space. The one thing we have seen is escalations going up. What has been 2% or 2.5%, we're now getting 3 and 4% on annual escalations because that's less expensive than building new for sure.
Oh yeah.
And so you really can move the needle a little bit on annual escalations at renewal because many of these leases that were done 8, 9 years ago are coming up, and those were in the 2% days or maybe 1.5s.
Right.
So
yeah, for sure. And is in the healthcare industry. So let's talk about Prospect Medical. I'm just curious if there's a lesson there. There was an article out that they filed for bankruptcy, and that was one of the this hospital chain's like largest tenants. Is the lesson just don't put all your eggs in one basket? Is that the lesson? Or is there something else going on in that article? I thought that was interesting.
it's steward number 2. That's all it is. We're serious. That's what it is.
Yeah, right.
And the report that came out from Congress before the announcement of the bankruptcy really brought that to light. They'd already highlighted Prospect as a problem.
Oh.
Right along with Stewart. Yeah, I mean, private equity has a place until it takes too much. And when it pulls too much out of a company, sometimes things go bad. And in healthcare, they don't like that.
Yeah.
Congress doesn't like that.
No, it doesn't. So but private equity isn't necessarily dead. It has a place in the medical.
It has a place.
Yeah.
But
right.
if you pull too much out,
yeah.
In healthcare, you can't react.
Yeah.
Like you can in non-healthcare businesses many times with private equity. But it's tough. I mean,
yeah.
It's
interesting. I didn't know Congress had their eye on them. So that's
there's a report for your next call. Go read the report that got published a week ago or 10 days ago. It's ugly.
Oh no, that's not good. That's crazy. Okay, well there you go.
Equity capital has no business in the healthcare, at least the hospital side. On the real estate side, they can come in and buy up medical office buildings and ambulatory surgery centers. But when it comes to the types of returns that they want coming out of the operations of the hospitals, don't know many hospitals that run profitable enough for that to happen.
Interesting.
John, your take from the system?
If they do, they're probably not interested in inviting them in. So,
right? Exactly.
No, that's a tough business to have a decent margin. We're a for-profit and publicly traded, so we have that pressure.
Right.
But yeah, a lot of this comes down to risk management and paying attention to who's investing.
Yeah.
Yeah, I think the scary thing is, and maybe we're a few years away from it yet, but all the private equity that's in the physician practices right now, we haven't seen the fallout yet, but it's coming. It will come. The last man standing is going to lose a lot of money. And we will see what happens with that, but it will be as traumatic, if not more so, than what we've just seen with Steward and Prospect for the hospital side, because the physician market is well entrenched with private equity in many specialties, and it's not just primary care; it's a specialist. And unfortunately, you've got young physicians who have no backup. There is no capital behind them. They've come on as employees basically to private equity. So the backup will have to be a hospital or somebody to pick them up because they have no infrastructure to come out and create an independent practice. There's nothing. So it'll be interesting. I mean, we went through it 20 years ago when we had public entities doing this and went through that. But it will come again.
Interesting. And
You're seeing a little bit of what I think is going to happen to the market. We're seeing an interesting movement of hospital-owned physicians that have now figured out it wasn't the deal that they thought they were going to get, and are getting out of their contracts, or their contracts are coming up, and it's time for them to move on. And more of that's going to happen.
the grass is always greener somewhere, right? People flip back and forth, I'm sure. I don't know. That's interesting. There is one trend.
Younger physicians are getting out of the practice.
Interesting. And they're not practicing at all? Are we
Nope.
having? Wow. Well, I don't know. I don't think I could take medical advice from an AI avatar. I'm just saying out loud. So I don't know. Maybe. Who knows? Who knows? Maybe we'll have AI robot nurses. I don't know. We still have a nursing shortage, right? We still have had that for like 30 years. So that's not helping.
Yep. Physician shortage too.
Yeah. Physician shortage too. Interesting. Yep. So it doesn't help because now there's record-setting enrollment in the Affordable Care Act. So what is that going to do? Is everybody else going to go? Now people are going to go see the doctor again? What is it? That's because of something happening in 25, like that's the last deduction, or it's cheap premiums, or something's happening. Is that why everybody's spurred on? Does anybody know?
Yeah, I think there's better tax credits for your premiums.
Oh, I see. Okay. So those are ending. So everybody rushed to go get healthcare instead of paying the $600 or whatever fine it was if you didn't have healthcare. But do you think it's going to spur on more doctor visits? Are we going to need parking garages in all those medical office buildings now?
It could. I mean, the number of doctors is probably going to limit those visits as much as anything.
Yeah, that's true.
When was the last time you scheduled a exam at your physician?
I never go to the doctor. I don't. I don't. And honestly, truly, I don't go unless it's like so bad that I can't figure it out myself, right? And so, and I come from maybe it's PTSD from my parents, because they always went. My parents they got the sniffles and they had to go to the doctor, and I'm like very much the opposite. Like I have to be bleeding and dying, and then I'll go to like, an urgent care clinic or something. But yeah, it's different for me. But I hardly ever go. And the same thing, my poor children, they don't hardly ever go. Like I'm like going, you're fine, you'll be okay, right? Like we'll figure it out at home.
Family practices nowadays, have triage nurses.
Oh, they do?
They do, to look at the severity of your call in for an appointment. And I've been with my physician for 24 years, but I'm still looking at 3 to 4 months if I want to go in just for a regular checkup. If it's an emergency, I'll get in a week. But other than that, it's not so easy to go see a doc anymore.
Interesting. And that's just because of the shortage of physicians. Shortage
of physicians and the number of patients that they're taking on to make ends meet.
And is that also the longevity of life now plays into that too. People are living longer, right? And I guess I'm assuming. I mean, I plan to live to be 120. I'm just saying out loud. I'm gonna be around for 70 more years. So is there? And then if we have is there like a storm happening? We got people living longer, and then we got shortage of doctors. Is that something we need to watch out for? Y'all think?
I don't know. We are living longer than we used to, but I don't think that is changing quickly anymore. It kind of seems to be sort of leveled off from what I've seen. But the storm that I've heard of is it's not just that there's a physician shortage. It's that the number of physicians who are near retirement age is pretty high.
Oh, okay.
So that's and the number of young ones coming in is not projected to keep up.
Yeah.
But the outside variable is there are physicians that come from other countries.
And they come here because they want better pay or better life or whatever.
Yeah.
Interesting. So, Well, I mean, I do see a lot. Well, I don't know. So are we, but I don't know. We have an immigration, czar now that I don't know looks, well, I'm assuming they're going to let doctors in. You would think they're going to let doctors in.
Yeah, I think they come through a different method. Yeah,
Crazy town.
they're well organized when they come over.
Yeah, exactly. They're coming in the legal way or whatever it might be.
Yeah,
Right.
yeah.
Yeah.
But I mean, if you think about it philosophically, they're coming from somewhere, and what about those places they're leaving? What do they do for doctors?
Yep.
So
For sure.
there's a limit. There's going to be a limit to that as well.
Yeah, I mean, at some point, I mean, so the whole telemedicine kind of things. I guess technically telemedicine. I mean, they're using it for triage in the family practices. It's kind of telemedicine. How bad are you? What are your symptoms? And they go through and they walk you through a lot of different stuff. I can call if I did want to call my doctor and talk to the nurse, and she'll do basic medical care over the phone with me. Right? She'll be like, "How bad is it really? What is this? What's happening? Try this first before you come in." Like when I did go to the doctor, I would do that routinely, and they were providing medical care, by the way, that they weren't billing me for, but they were. And I just find it interesting that the telemedicine thing didn't take off more, but
yeah, it took the pandemic for it to start to get reimbursed seriously. So that's why it's more recent than people thought it was going to take off a long time ago.
Yeah, for sure. I mean, are we just waiting for the next pandemic? And then maybe.
I think there is some telemedicine happening in limited applications, but yeah, I'm not sure I know sometimes people see specialists or they see a physician for a simple appointment or checkup or a follow-up. But for the real in-depth exam, it's kind of hard to do that remotely.
Yeah. So where do you think?
Most of it is
Go ahead.
things like behavioral health, big presence there, and follow-up visits.
Yeah, don't necessarily need to come in for that, right? Unless something's
Yeah,
wrong.
I mean, they can ask you the same amount of questions. The only thing that they don't get to do is take your height, your weight, and your blood pressure.
True. Yeah. But there's going to be something like that on an iPhone that'll do that for you, right? At some point, it'll take your height, your weight, and your blood pressure, and then you can just turn that into your. Then there's got to be a watch or something will do that, right? I don't know.
I mean, right now the scales, your blood pressure, all of that is available over the internet.
Right. There's got to be some wearable device. I would think that eventually that's where people wearing devices that monitor the health that their doctor will actually have access to that can help, I don't know, maybe streamline doctor visits. Like maybe it calls you and says, "Hey, you're about to have a heart attack," because we can tell. It's like an IoT sensor for your body.
You better get in here.
You better get in here because you're about to kill over, man.
Yeah.
The problem is those devices aren't quite as accurate as what the doctor wants.
Aw, really? Oh, maybe it'll be one of these days. I don't know.
That glorified check engine light.
To glorify check engine light.
That'll be that ring or that watch that you wear, definitely.
Exactly. Yep. So are you seeing AI deployed in any or any sort of AI agents deployed in any major way yet in hospital or in medical office practices? Are y'all seeing any of that? Because I talked to my sister, and I'm going to say who she works for because I'm probably giving away secrets. But she works for a large medical equipment device manufacturer, and they are using AI to help with patient outcomes. So I'm sure this is not, private knowledge. So, but it's interesting. So, what are y'all seeing on the practice side?
One area that AI is trying to grow in is the whole medication error side in the hospital. We've had the technology on the computer side, just the screening that catches potential allergies and medication air conflicts. But the error side has a human factor to it also, and the AI use there and how they're looking at the data and predicting circumstances that will lead to medication errors is pretty neat. There's a couple companies really doing that research right now. They can actually predict when the high incidence of medication errors.
Interesting.
Because that's a real problem in the hospital world.
Yeah, interesting. Is there any sort of applications on the real estate side that help? Like, I don't know if I mean, we're doing a lot. You do a lot of stuff with occupancy censoring, and you do a lot of stuff with. But I'm assuming when you look, I've gotten those instruction packets when I left the hospital and went home, and I didn't follow those suckers. So if AI can help me, like, make sure I do what I'm supposed to do, I don't even know where that packet goes after I get home. I like throw it away, I think.
It might help with that. One place we're seeing it is, we're big enough that we go through a lot of transactions, a lot of lease transactions, and AI can help with some lease abstracts.
Yeah, no, it doesn't now.
Kind of shorten, but that's kind of minor as far as, it's a little bit of a productivity boost.
Yeah, for sure.
Yeah, from a real estate perspective, it's primarily making sure that you brought enough cables into the building, enough providers. I mean, it's the last building we did, we brought in 3 separate providers because everybody wanted to have this system or that system. Everybody's got to get on the same wagon one of these days. And,
yeah, good luck with that, Chuck.
Oh yeah, well, I mean, you look at the problems with electronic medical records. You go to this hospital. You take a market like we have here in Denver, where you have 5 different systems, and you can't get your records from one place to the other. It's aggravating for the patient.
For sure. Yeah. I think that needs to be fixed for sure. I mean, just like it's amazing to me that it's the same thing that we're doing on the building side, but you basically have your medical passport, or like have all your medical records and I don't know what they say because the doctor's got to look at it because I can't read the damn thing. But if we could just have it with us, and then it's easy and to transfer it to, so you have it. I don't know. I think that you're right on the medical record side would be great to have that, right?
Yep.
Pretty easy to move around. Interesting. But HIPAA, there's this thing called HIPAA, and I don't ask me how it solved any problems other than people not sharing information, but it just caused some problems too. I'm sure y'all love HIPAA. I'm sure it's fabulous. So everybody loves HIPAA. All right. Well, look at that, y'all. See, I told you this. I tell everybody, these shows go fast, and we have such a cool time, and we have all these fun conversations. So look, we're at the end of our hour, and it just went by so fast. So let's do some outtakes of people. Like, just give us an outro. Like, if you want people to get a hold of you, feel free. Tell them how to get a hold of you if you like to do that. So go ahead, Chuck. Start.
From our standpoint, I can be reached at chuck@cohcp.com. Again, we're a small developer working in the state of Colorado. We try to work with the systems to get their outpatient facilities, and we work in a retail environment. So we're trying to put them in the shopping centers, just not in the shopping center buildings.
Very cool. And John?
Probably the best. A little different role with the healthcare system, but probably the best way for me is to go through the LinkedIn profile.
Yeah, LinkedIn's great. Yeah, for sure. And Deanie?
Everybody can watch on LinkedIn. We will launch a new website and a whole bunch of new information on Landmark Healthcare next week. Should come out. So that'll be the best way to follow up.
All right. Awesome. Well, thank you all for coming on the show. This has been a show of the U.S. PropTech Council. We're here every week. We'll be here next week, Tuesday mornings, talking about more healthcare real estate news. So thanks for coming. It's awesome.
Bye.
Bye.
Thanks. Bye.